Okay. My name is Dr. Claire Georges, and I'm working in PAS, in Saint-Louis Hospital in Paris. And maybe I will make a remark to Andrew. The PAS are outpatient units which are dedicated for people without social coverage. And these units are composed with general practitioners and also nurses and social workers. And patients who come to our unit are usually suffering from many diseases. And most of all, these diseases can be due or aggravated by social problem and by their way of life. And I wanted to point out that this kind of situation illustrates the limits of our specialized and standardized medical system. And in fact, I observed that in our hospital, most of the medical system is more and more specialized and technical approach. And I would like to evoke here that the global medical approach that we have in this unit seems to be beneficial for both the patient and maybe also, I think it's also cost effective. That's the remark I would like to make after your intervention.
Okay, thank you. Yeah, I think a couple of points to make there. One is that this model of payment, the DRG or GHM payment system, works quite well in the hospital sector, where patients tend to be, the model is work based on patients usually having one problem that needs to be managed. And it's a fairly discrete event. So that's why this payment system in various forms has been adopted around the world for hospital funding. It works less well when we're dealing with patients who require care from different providers outside of the hospital over long periods of time. People with chronic conditions, long-term conditions. And those are the patients that we as a society need to be thinking carefully about in the future, because the burden of disease is growing greater for this group of the population than for the people treated in hospitals. And in fact, the hospital is going to become much less dominant as a player in the healthcare system over the next 10, 20, 30 years. And our healthcare systems are not currently structured to meet the demands of the population who require care in lots of different settings and over continuous time periods. So the models of funding and the models of care and the integrated care arrangements that need to be developed, by which hospitals work with general practitioners, with social workers, with community healthcare providers, are the big challenge that we need to feed into over the next few years. And that will require a different funding model, a more sophisticated funding model, and a different way by which we as actors in the healthcare system work together. There are steps being made to look at integrated care arrangements, integrated financial arrangements, and I think that is where the evidence base needs to be made stronger and where policy needs to support development of that evidence base.
Hi, this is Doğan Fidan from Sanofi. That's also a question for Andy. I mean, if I understand correctly, that your research showed that the particular hospital was in fact receiving 12 million more pound than it was actually supposed to. So did you look into a little bit more detail, trying to understand, I mean, what were they doing with this money? Is there any obvious inefficiencies in the way that the hospital is run?
Well, we've obviously had some heated discussions with some of the representatives from the various hospitals, particularly those who are most affected by these types of arrangements. And there are a number of things that they need to look at to work out what is going on. Some of them are quite simple. Some of them had really poor data, both on, they weren't returning the requisite data on what was happening to their patients, or their cost information was really poor, which meant that they probably had a really poor understanding of the relationship between their costs and their revenues. Those things are quite easy to fix. But then there are other things that are going on within those organisations that actually do require managerial attention. How long are their theatre sessions? Are they being scheduled correctly? Are their beds being occupied to optimal levels? And really, the job of, as Marissa puts it, the principal, the payer of the hospitals, is to provide incentives and signals for hospital managers and finance directors within hospitals to actually look at what is going on in those in their organisations. But to make sure we've got the right incentives, of course, we need a good evidence base to make sure that we construct those incentives correctly. But the job shouldn't just be on analysts to solve all those problems. It should be a dialogue, and a dialogue in terms of setting the incentives and in ensuring that the organisations that are affected by them actually look internally to solve the problem.
I just want to make another point on...
Introduce yourself.
Oh, sorry. I'm Karine Chevrol from APHP and Health Economics in APHP, in units dedicated to that also. And I just want to come back to your study. You said you're doing this study because you want to disentangle the effect of a good bargainer or having more complex case. But what we see, I mean, from what I get, is like, for instance, for children, specialized care are very much concentrated in some hospital, which means that they are good bargainers, aren't they? So, and when you measure the fact that they are like spending more on case, is it really because they are more complex, or is it because they've been good bargainers, so they can be inefficient and spend more on them? And it's just to come back to Lee's chair, saying like maybe there is a good opportunity there because she will have like medical statement on patient, maybe to have more idea of the severity of the disease, and then link clinical data, which...
Okay, so I set this up as a fairly crude model of bargaining and inefficient information to inform the design of the payment groups. I actually think specialised care is a good thing. I think it's important that services are concentrated in centres of excellence, because actually the outcomes associated with delivery of care by specialised teams indicates outcomes are better than if complex patients with complicated care requirements are cared by people who only deal with those types of people on an infrequent basis. So actually specialisation and concentration of care should be encouraged in most of our countries. But it needs to be funded correctly, and it needs to be funded fairly. So in planning the hospital sector, we need to make sure that there are incentives in place so that the system as a whole is configured correctly. You can't just rely on the payment system to do that. There needs to be a debate about how your services are configured correctly across the whole of France. And then you need to ensure that the payment system that supports that configuration of services is correctly structured. And my evidence was that the payment system needed refinement, and I was able to provide an evidence base to work out in what areas it should be refined and to what extent. The difference between the bargaining and what I believe is the correct payment system, I have put down to differential bargaining, but probably there might be other things as well.
Patrice de Goulet from Pompidou University Hospital, one of the assistance public hospital. In the gap between the 75% and the 20%, I would like to know if you could comment on three possibilities. First is the bulk of education, because in highly specialized you may train more people, what it could represent in the 75%. The second, in our case, we have an electronic record which is integrated with the data bank of good practice up to date in our case that come from Harvard. So it means that can push the specialists to make more procedures that are within that will not be done in a general hospital. And the third explanation is the percentage which is dedicated with intermixed research. Because in many cases in France, you know, there is some part which is taken in charge by the general procedure, but in fact that should be paid by the clinical research.
Yeah, so hospitals actually are multi-product organisations, and they don't just treat patients. Some hospitals do other things. They provide training and education, and they undertake research. And there may be some cross-subsidisation between those three streams of work. But just as I think that we need to be developing a payment system that is optimal for the delivery of patient care, I also think we need to have a payment system that is optimally designed to encourage medical education and that supports medical research. So our ambition should be to say that those elements of activity, insofar as they are valuable, need to be funded appropriately, transparently, and to ensure that they deliver the educational outcomes that we wish to secure. And I'm certainly in England, the way that medical education has been funded in the past has been somewhat opaque. But there have been steps to improve the way that funding is allocated. So it's now much more related in a similar way to the activities of education that are undertaken. I don't know how it is in France, but I would hope that you have a similar type of arrangement whereby education is related to the efforts that are made in providing educational products or research products. The complexity will be disentangling the joint product, and that is always going to be a problem. But again, there is a reasonable research base that one can appeal to try to provide information about how to disentangle those elements. And that is something that I think payment systems need to evolve toward.
Thank you very much for your presentation. I'm Martin Hirsch, Director General of the APHP. I have 2 or 3 short questions. The first question is, none of you have mentioned any controlled trials in your surveys. Do you think it has a greater place to have or not? What's your opinion on that? My second question is to answer to the question, is health economics research having an impact on policy? Every doctor thinks that the impact should be to increase cuts in budget. On the other hand, do you have any surveys showing that invest in something or invest in prevention can have a positive impact on savings, and that there are a way to reallocate these savings to the actors if you promote prevention or investment policy or quality policy? Do you have some encouraging results or surveys for us on this field? Thank you very much.
So I'll take the first question. Yeah. So this is about the trials. So I think economists in the past have not been used to the idea of trials, but I think there is convergence in the sense that what you see in the literature is that natural, what economists call natural experiments, is what everyone is desperate to find in this in the empirical evidence. So it's quite hard to actually policymakers to fund the actual experiments. So because basically that says, okay, you're introducing a policy and then you split the country in two, and in one half of the country you introduce a policy intervention and the other ones you don't. So because that happens very rarely, then the economists have been a little bit unusual to that idea. But in the recent 10, 20 years maybe, the idea of the natural experiment has come in, which is the idea that you have a control group and you have a treatment group. But that happens a bit by chance, in the sense it's a natural experiment, in the sense by chance the policymakers have done something in one area but not in another area, so that then you can evaluate the effect of that policy. So there is an emerging big fields in development economics where they actually where economists try to do actual experiment. But I think this is a little bit easier to set up in developing countries. So, for example, things that don't necessarily have to do with the health. So, for school, you pay some teachers to show up for teaching, and in other schools where you don't, and then you try to evaluate the effectiveness of the policy. So, little by little, this is all coming up together, and there is convergence in the sense that the economists are used to the idea of experiments and trials. And possibly, maybe actually, the medical field is also coming towards us in the sense that anything that was observational studies was just looked at about something unacceptable. I think these days maybe there is a little bit more of you can use observational studies to evaluate some policies, because you don't always have natural experiments. So what do? You just take you just decide on policies based on no information, or you actually make some sophisticated econometrics corrections to get the correct answer. So in that sense, I think there is a bit of convergence. So maybe I'll let.
I'll mess up with a little bit of political economy on this, because it's just not a matter of putting the control trials. I think that's nowadays we can agree that's kind of the golden standard to get causal relationships and see what is the effect. I think the problem is not really on defining the idea. The problem will be on implementing the idea. In terms of dealing with the political pressure on it, and also with the tendency to mess up with the control trial itself. What I mean by this: first, if you're doing it, say in Paris, suppose that you divided half the hospitals with something and half with another thing. If you have someone that doesn't like you just say you are hurting half of the patients because they are not receiving the golden standard. Whatever is the right side. And I think that if you talk about policy at the government level is one thing. If you talk about deciding inside organizations, can be slightly different and maybe easier to do. The second thing that I see often on these pilot experiments of trying to get control trials is the tendency of people to select winners. They say, I want to try a new organization method, but then I'm going to pick the guy that actually is more suited to make it succeed. But then it's already biasing. Exactly. But you often see experiments doing in this way, right? You select the guy. The second thing that you need is persistent. Sometimes you need to have more persistence to see the results coming. And if the actors that put the policy in place change, and sometimes the policy experiment may take longer than the cycle of the appointment, that will create the issue of what is a continued political support or organizational support to do it. Also, if it takes too long, you're going to build resistance to the experiment. So in a sense, you don't get a real control trial because the resistance to the experiment will appear from the guys that don't like it in the field. And so you can consider it part of the experiment or not, maybe difficult to deal with that part. On terms of the second question that you had about prevention, which is something that I have wondered myself for a long time. Why don't we see more about the benefits of prevention once it has become widespread view that pays off? I think that the basic issue is that with prevention, we want to measure long-term impacts into the future of something that does not happen. And we are used to measure short run of something that has happened. I think that is a challenge for most of the professions associated with healthcare, is try to define what will be the best way to define what is the impact of something that we don't see and that we don't want to see. And I think that's a major challenge for us.
And I I think you've said everything, but of course, for us, the RCTs are extremely important, and if we could choose, then we would implement RCTs for every single thing that we analyze. What I wonder is what is the openness of policymakers in, for example, launching sequential pilots to test policy. What happens if they don't work? So I think politically, I think the political barrier is actually the main issue in this arena. But also, it's extremely important that we move towards building, international centers that gather evidence and make evidence available systematically for policymakers. We don't need to reinvent the wheel. We can learn from international experiences and incorporate that in the political or decisions within our national healthcare systems. Again, of course, that depends on the quality of the evidence and the context or all the contextual factors that might impact on the policies. But if there have been pilots tested elsewhere, and we can infer somehow on causality, then maybe there are lessons to be learned. And what I see in many policy areas is that many healthcare systems tend to invest on policies that have been proved not to work elsewhere, just because that's the natural thing to do, follow whatever other healthcare system is doing.
Sorry, I just want to say something more about, give an example of the issue I was mentioned before about natural experiments or trials in the policy domain. So a while ago I was asked to comment on a Cochrane review on policies on the waiting times, which is something I've worked quite a lot. So I looked at the report, and the Cochrane criteria is that actually to be covered in the review, this has to be a trial. And so basically this review had no studies in it because there are no trials on waiting times policies. So, but still governments are interested in waiting times policies. So I think the point is, as Petra said, addressing causality. If whenever there are no trials, if we can address causality in different ways, maybe with more sophisticated econometric techniques which economists are familiar with, then that's fine. So I think causality is the issue, and non-trials can be complements to trials.
Okay, so maybe Marc will probably continue. Marc Gurgan will probably continue in the next roundtable, or will that be ILF? I don't know. Anyway, so there will be some some continued discussion about that. But just me, if I can just add a word, the evaluation process is a very risky process, and risky for all parties. I mean, we take the chance to learn something that we don't want to learn. Okay, we really must be prepared that if we start an RCT or any evaluation process, we may learn that our idea, our intuition was not correct, and that is something which is very, very difficult to. It's true for the investigators. It's true also for the sponsor. Okay, and in most cases we all want to prove that it works. Okay, it's very, when we find strong evidence that it doesn't work, then comes difficulties, and this has to be planned well ahead in advance. We need to be aware of that. That probably refers to the policy or the policy risk or the political risk about this. It's sometimes it's dangerous to learn and to look at to investigate. So you want to compare?
Just one final comment. That as academics, we tend to, well, many academics tend to want to be involved mostly in the evaluation of the policies. But I think it's extremely important that we are also involved in the design and in the implementation process. Because then either it's too late for us to do anything about the quality of the data, or we don't really want to put our hands on that because maybe our internal incentives within our institutions require a certain level of publications. So there should be much more involvement at early stages.
Annie Chicoy, SS Business School. I have two comments and then questions. One for Andrew Street. I think that the way that you showed, with evidence that, and given the definition, correct me if I got it wrong, but the definition, that you gave for specialization was based on combining ICD codes, specific ICD codes, and specific medical procedures. Okay, given the results that you showed, which were probably, completely correct from an econometric perspective, my first question would be to question the definition of this specialization. And to go a little bit further, I would think that you mentioned that, especially for specialized academic high-level hospitals, there is this cross-fertilization between research, between care, and between education. And some people probably in this room know it better than I do, but I think there was a lot of efforts spent on disentangling those different factors to assess, where the value lies and what comes from what. And at the end of the day, for policymakers, it was so complex and so difficult to sort out and so difficult to manage from a political perspective that a much simpler solution and not so fair solution was adopted, making specific allowances for education and research in the French academic hospitals. So that's my first comment, and it's also related, with the how far health economists can impact policymakers, because they don't they have some limitation in their recommendation. You know, if you don't take into account the policy and political environment, as you very showed to us. And so I just would like to finish with one question to Marisa Meraldo. Thank you for this review of pay-for-performance experiences so far. And again, my question would be, would you recommend, because the evidence so far is a little bit limited, would you recommend not to pursue and not to go further?
No.
It's a policymaker, the question.
And I think these... No, I would. What I'm trying to say is that even myself, I'm not entirely sure whether it works or not, and I don't know if it's due to the design of these policies. I don't know if it's the context. It all makes sense within a specific context, or if they don't work. You know, there's plenty of evidence in other sectors other than the healthcare sector that pay for performance actually doesn't deliver desired effects. So there's something we cannot rule out. However, in order to assess that, we need to be able to link the different items within each policy with the impact, and we cannot do that. We need to make use of these international comparisons, but data doesn't allow us to do so. So my answer to that is that I don't know. I would have expected pay for performance to work as an economist, but we still have a lot of work to do. And it needs to be a collaboration between policymakers and academia, not only economics, and at very early stages of the discussion, not only the evaluation.
So, shall I answer the question? Sorry. So let me let you into a little secret. I mentioned that they changed the definitions of specialised care in this last year. So they had a new committee, a new working group that basically reviewed all the diagnosis codes and all the procedure codes, and this was sold as just an update and a bit of a modification. Same principles, a little bit of a tweak. But when they did the update and changed from the specialist services national definition set to the prescribed services definition set, nobody in that design team thought to compare the two systems to see how they actually compared in terms of who was defined as having specialist care or not. So we had to do that work as part of our latest analysis. There's hardly any overlap at all. Everybody was completely surprised. You know, it strikes me as pretty obvious. If you're going to redesign things, as part of your design, you ought to do a bit of a comparison. So again, coming late into this as a health economist, if I'd been there on the design team to look at that, I'd have said, why don't we do a bit of a compare? So, of course, now the task has been to see what the implications are of a completely radical overhaul of how we define specialised care. The nice thing is, of course, we can explore that because we have all the data and we can compare what happens to hospital revenues under one definition set with what happens to their revenues under a new definition set, where different patients are defined as having different types of specialised care. So, you know, we can actually evaluate the implications of having a different set of definitions given the information that we've got. On your second point, what I've understood over the years is that when you're negotiating with hospitals about their annual budgets and how they can be paid, hospitals always have an excuse as to why they have higher costs and ought to have larger budgets. And they will always come up with some excuse or another as to why we are in deficit this year or we need more money next year. The job of the analyst, the job of the payer, the job of the policymaker is to evaluate those excuses on a sound basis and to ensure that where evidence is missing or data are missing, that there will be an imperfect solution in the short term, but we ought to be moving to solve those more intractable problems in the longer term. We'll never have a payment system that is perfect at any particular point in time. It's a repeated game, and that repeated game is about evaluating excuses and being able to moderate the impacts of those excuses over time so that hospitals are paid for what they do and on a fair basis. But we will never have perfection. At least I hope we don't, because then we'll be out of a job.
Yeah, Anne Gervais, Paris, Bichat, at PHP. I have one remark and one question. The first remark is we had the same idea in France that all the DRG were not enough to reveal the whole reality of life and death and health. So we have now 2,400 DRGs. So maybe that's not enough. Maybe we have to go on to 60 million DRG, one each. I don't know. So that's the end of it's a joke, okay? You don't have to answer.
This is a sensible point, because I put the revenue function in very simplistic terms, quantity times price. But actually, the revenue functions are much more complex than that. There is a much greater appreciation that you need risk sharing between the payer and the provider when you don't have perfect information. And the payment systems are not just around a GHM times a price. There are also payments for people who stay beyond a specific time in hospital. Or you might have block contracts for some elements of service, like your A&E department. So actually, the revenue function is a complex bundle of different payment elements. And the reason for that is you will never get perfectly resource homogeneous groups. So there has to be a limit to where you have absolute perfection in being able to predict the patient's costs, and a more sophisticated payment system that when you don't have that information allows the risk to be shared between the payer and the provider, which is why we actually do need quite sophisticated payment arrangements. We need sophisticated payment arrangements, not complete simplicity, because actually the delivery of care to individuals is a really complex task. And patients have sophisticated, complex care
So
needs.
maybe we have to be imaginative. Some years ago in Paris, we said imagination power. So that's the same point. We should maybe think about a budget given not just to make the hospital survive, even in a where they have no activity, in a zone where you need to have a hospital or a physician. So that's the first point, and we agree. And the second thing is a question. Do you know, Professor Meraldo, any service of public interest, like justice, or where you have P4P efficient? So that's a problem. So I don't understand Professor Siciliani saying, okay, we don't see it's useful, let's go and do more.
Well, again, I mean, it does, sorry, thanks. It doesn't, again, the evidence in the other fields is that in many business sectors, that it doesn't tend to work alone, this type of financial incentives. But again, do we really know why it doesn't work? Is it just something to put in textbooks and then move on? Or do we need better evidence and better data in order to assess whether it's really the design, it's just the wrong theory, or anything else? I'm more for the idea that we should go back to the drawing room and try to, if you want, go a bit deeper in the questions that we make regarding the effectiveness of pay for performance.
So, just wanted to make a comment on all of this. So, regarding the DRG groups and the fact that we keep increasing them, I mean, there is a point where, in a way, we should stop, because if you go to the extreme where you have one DRG for each patient, this is basically cost reimbursement. And we already know what happens with cost reimbursement. You just have you will have expenditure, which will just keep increasing. So, on the other thing about DRG payment system is that, well, we know that these have limitation. They tend to reflect cost. So perhaps it doesn't sound like a bad idea to me that you integrate a quality component with this DRG, which basically is the pay for performance scheme, where basically you integrate a bit of quality performance with DRG payment. I cannot see how you can. There was a question whether we should do pay for performance scheme. It could be that maybe we don't want to have pay for performance scheme, but I don't think we're going to get rid of the quality measures. I think these quality measures are out there, and they're going to be there. We can use them in different ways, but this will not disappear very soon.
Randy Ellis, Boston University. Sherry Gleed behind me and myself both were going to comment that, of course, the legal system uses pay for performance in the whole damages and tort cases in many countries. The question I wanted to ask, though, is the title of this session is health economics research having an impact on policy? And implicit in that title is academic health economics research. In fact, I think the group here would tend to say publicly funded academic research because, of course, many academic economists are also hired by the private sector. And so the question I wanted to ask, and I'm going to target Pedro and Andy because I think they spend more time talking to policymakers and perhaps even the private sector, is health economics that is not publicly funded or not academically motivated having an impact on economic policy? What are the good, the bad, and the ugly?
Thanks for the question.
Okay, good. This was an arranged question because I have the answer for that. Thank you, Randy. Actually, a couple of years ago, 2 years ago, I had an approach by a private sector entity for work, and in which Alberto collaborated as well in the final part. And it was the pharmacy sector, which will be on strike here tomorrow, if I am correct, because they want to sell pharmaceutical products in supermarkets also here, and they are resisting that. Okay, but what happened in Portugal with the Troika when they got in? They stipulated a gain to be obtained from pharmaceutical distribution of a certain 50 million euros. They phrased it wrongly on the first part, doesn't matter that. The question was, are the measures that the government adopted already sufficient to give that 50%, that 50 million savings to the government budget? And so the National Association of Pharmacists asked me, as a private organization, whether I would be able to try to come up with an answer, because the government was checking it independently. So for me, it was a risk, being captured by the association, right? I decided to take the risk because I wanted to have the hands on the data they had. Okay? That was basically the point. Now, the interesting part on this is that we went to see what was the change since the competition authority in 2005. Rephrasing. 2005 competition authority in Portugal used the model to say that there is a gap of 5% that could be saved on pharmaceutical prices, on the distribution prices. And so our first step was to see, is this gap already closed or not, and what is happening in the sector, and to see whether the 50 million were being saved or not. So we went there with the private money, and basically the guys from the other side wanted us to show that yes, and they were going to fail all around the place. What we found was they have problems, but we detected that the change in cost structure was the basic thing that was happening at the time. And since 2005 to 2011, they changed the rulings about the space, office space of the pharmacy, how many people needed to be there. All of this increased the fixed cost and decreased the marginal cost in a sense. They have more fixed inputs. So our recommendation is to say, forget about saying that pharmacies are going to fail. We don't care about that as long as the network keeps on. So if someone made a wrong investment and bought a pharmacy by 1 million and that was a wrong investment, too bad. Someone will replace it. So the true question is going to be if someone exits, will be someone that replaces it or not. That will be the key question. And then saying, okay, with the cost structure change that we had in the system, that's going to be hard. With the price decreases, and price decreased 25% during this period due to the drop in generics, and some of the generics dropped more than 50%, and the revenues of pharmacies are a margin over the price of the things. Our recommendation was to say, look on the cost structure, try to deconnect what is the revenue of the pharmacy from the final price that is sold to the consumer, so that the final price of the consumer can go down without hurting the pharmacy distribution, and actually there's no reason to make this proportional. And then think what measures can you take that will actually revert the fixed cost times marginal cost structure. Now, we put this on a report. It was delivered to the private entity, to the National Association of Pharmacists, which delivered it to the government. The government wanted to talk with us privately, which we did. We didn't announce anything. And in August 2012, they lightened the regulation on pharmacies, and now they are moving to a more fixed component on the cost structure, on the remuneration of pharmacies. They will be on strike anyway because they always think that's not enough. That's a different matter. But it's one example where you have a private entity coming in, asking. We are not delivering what they asked for. We delivered what we thought it was the right position, and they made to the government as well. They start to change that. Next step was to think new models of paying pharmacies. And that's something that is still on debate. We collaborate a bit on that. Now it's up to the political process. We are out of it already. But I think it answers your question that we can get this sort of intervention by something. Did I come unpolluted out of this? Well, it's up to the other people to judge.
So, and did they call you back afterwards?
Which side?
So the private market for research in England and perhaps in the UK is tends to be delivered by consultancy firms, the big five, PricewaterhouseCoopers, McKinsey's, Ernst & Young, and so on and so forth. And actually, they have a big influence on policy, and hospitals also get their advice when they want information to inform what they're doing. Of course, they offer a very different product to what academic researchers do, but sometimes there is a bit of an overlap. Quite a few of the hospitals that have been facing changes in their revenue as a result of my study have hired these consultancy companies to try to work out what is going on and to work out what their strategies might be to address the problem. These consultancy companies often promulgate the idea that, for example, competition is really good in the healthcare system. But what's interesting, I find, and what I find somewhat annoying, is that they operate as a cartel. And in fact, hospitals are required, if they're getting consultancy advice, only to get it from the big five consultancy firms. Which means in England that they don't compete on price and they charge very high fees. Their fees are somewhat higher than the fees I charge for my work. I actually think if you're going to cut costs in the healthcare system because you're faced with overall budgetary problems, one of the things would be to break the consultancy firm cartel and actually allow the market for advice to be much broader than is currently the case. I don't know if that is the case in France, but I'm certainly not very happy about that situation in England.
Okay, thank you.
And as you can imagine, the consultancy firms are not overly happy with me.
Shall we make one now?
Well, Serge Usan, I am the Dean of the University Pierre et Marie Curie Medical School. This is a member of the cartel of the Big Three in France. And I would like to make a comment about what Pierre-Yves Joffard said. It could be dangerous to conduct trials or experiments because sometimes the result is disappointing. We know that very well in medicine. All the very well-known things were completely wrong. And now nobody in medicine is trying to use principles which were not tried. Moreover, 20 years ago, when you have a trial and the result was negative, there was no difference, it was very difficult to publish it. Nowadays, this is completely different. You have to declare the trial before beginning it, and you have to publish your results. This is mandatory, and perhaps it could be a good way for you. Don't be afraid.
No. Well, it's yes. It's actually this is actually a very strict a very strict policy at PSE for all studies and evaluation processes we impose the freedom to publish the results. Whatever the result is, so it's something but we tend to insist on because I think it's of course it's not that it's dangerous to learn. I mean but yet it's risky. I mean there are some times when you prove that something doesn't work, and when the sponsor wanted to prove that it worked, it's rough. Okay, it's a bumpy road, and. So we have
it's no more now in medicine. The sponsor, even if he has the right to publish the results, you have the right to make a comment, and you can make a comment which is a devastation for the sponsor.
Yes.
So they are quite prudent with that.
Yes. So what I was just saying is that this has to be very clear ex ante on both sides. So that there is no major surprise. But it needs to be thought of in advance.
Let me just add one example where the things will work differently in health policy. This was an experiment. Try a new model for primary care in Portugal some years ago. They decided to put some money for a different organization of the primary health care center there and try to see what's going on. So according to the principles of trying to do this, you should set evaluation principles, but you also should assure that the experiment would have the commitment from public money long enough to produce the results until you could reach a conclusion, right? Now, what happened there is that as soon as you started the process, the political pressure disappeared because the minister have cut the ribbon already, and then he withdraw the money from the experiment before you could reach any sensible result. And it is this commitment of getting from political power to give the money long enough for having the trial working that constitutes a danger in this process. So in a sense, when you start a trial with a pharmaceutical company or some device company, she's committed and she's more or less forced by contract to go up to the end and give you the money to do the results. With government policy, you often don't have the commitment to give the funding to get up to the end to see the results. I think that's where the danger, one of the dangers lies, and that's what makes one of the differences.
But also academically, still in social sciences, we are still, very much more biased towards positive results than in medicine. Maybe as medicine was some decades ago. But I think also in policy, there's not too much investment on learning why things don't work. So if a pay for performance doesn't work, doesn't mean we shouldn't abandon it. We should understand why and what are the lessons we can take from there for the next policy design.
Yeah, we just had a short comment about that in the sense that there is publication bias, as we have said, but I think we increasingly see papers that are published with a strong null. That if you have like a good identification strategy, then journals will publish these days if you have done a good job with no result, basically. So I think things are improving, but maybe we're not as far as you are.
Okay, so things are improving. I think this is a very good way to conclude this session, and things are going to improve. So thanks a lot to all of you. I think now we have time for a break.